Good evening and welcome all to the Wednesday evening webinar of the Indian College of Anesthesiologists. Today, we are opening discussion on resuscitation medicine. We all know, or some of you would have heard, that resuscitation, or say the cardiac resuscitation following a cardiac arrest, starts in mid-1960s, which later we renamed as cardiopulmonary resuscitation and further down as cardiopulmonary cerebral resuscitation. And today the name is CPCR. And the World Authority on the Resuscitation Medicine is the American Heart Association with help from International Liaison Committee on Resuscitation, which otherwise we say ILCOR. And the AHA, or say American Heart Association, is controlling all the modalities and the protocols and the guidelines on the resuscitation medicine. And they publish or republish with the needed amendments every 5th year on the protocols we follow for the next 5 years. And further change, depending on the response from everybody, as well as the advice of the ILCOR, they redo it after 5 years. The last amendment, which was done in October 2020, as the amendment to 2015 amendment, is being discussed today. And today, discussing on the adult CPR and the emergency cardiac arrest care, or say CPR and ECC in adult. And further parts we will be discussing it later. Today, discussion and the webinar is handled by our moderators, Dr. Raminder Sehgal and Dr. Saneesh PA. Raminder, I don't know to tell about Raminder to you. Raminder is our chief editor with the Yearbook of Anesthesiology. She is one of the distinguished emeritus professors in India. And Saneesh is our backbone with this webinar. With these words, I request moderators to introduce the speakers and open the webinar of the evening.
Thank you, sir. Thank you for the introduction. So we start by introducing the two speakers. We have two renowned faculty in the field of resuscitation medicine, Dr. Nigel Kuriakose, who is based in the Sultanate of Oman, and Dr. Ajith Venugopalan, who is the head of Department of Emergency Medicine at MOSC Medical College Hospital, Kolancheri, Kerala. So both of them are AHA accredited BLS and ACLS instructors. Dr. Nigel is alumnus of KMC Mangalore, and after having done MD anesthesia, he has also acquired additional PG diploma in regional anesthesia from France and diploma in pediatrics from Ireland. He is also the president of the only Pravasi IMA branch, which is based in Kerala. Dr. Ajith Venugopalan is MD in emergency medicine and also has a PG diploma in medical law and ethics. He is fellow of the Academic College of Ethics and Emergency Experts, and as well as fellow of the intensive care medicine. And he also surprisingly holds the Guinness Book of Record for training 28,523 students or trainees in 2019 in 8 hours. So it is a Guinness Book of Record. So I think we'll start by inviting Dr. Ajith to start the lecture. Dr. Saneesh, would you like to introduce the methodology today?
Yeah. Good evening, everybody. Today we have planned an very interactive mode of discussion because this has been a hot topic since the latest resuscitation guidelines were announced late in October 2020. So we will be discussing based on that, what are the latest recommendations and the science behind that. After that, we'll have mega code scenarios, case scenarios with, we'll invite postgraduate delegates in the audience to participate. So you will be getting a chance to respond as a team leader in a peri-arrest, cardiac arrest, and maybe a return of spontaneous circulation scenario. You will be shown the live hemodynamic monitor depending on the scenario that we are discussing. And as you run the code, we'll be running the code uninterruptedly, and then we'll do the debriefing, and we'll see what went right, what went wrong, and what could have been handled better. So that's the way we intend to emphasize the science behind the resuscitation updates. I think Dr. Ajith has a few audience poll questions also during his lecture. So it's not just about relaxing, sitting back and listening to the webinar. From the audience side also, you will have many opportunities to make your suggestions, comments heard. And during the lecture itself, you are welcome to post your query and suggestions in the chat box. We'll try to address all the suggestions and query in the chat box as much as possible. Okay, so Dr. Nigel, would you like to have a starting remark, and then Dr. Ajith can take over?
Thank you very much, Dr. Saneesh, Dr. Radhakrisnan sir, Dr. Raminder. It's an honor to be part of ICA's academic activity today. It's a great privilege, in fact, to be invited. And I'm sure we can do justice to what you expect from us. I think Ajith is also a very good instructor when it comes to all our AHA programs. And I think we'll be able to do, like I said, we'll be able to do justice to all the questions and all the queries also that you have in place for us. Thank you. Over to you, Ajith.
Hello. Good evening to one and all. It's a great honor to be a part of the Indian College of Anesthesiology webinar. It is a big thank you to Dr. Saneesh, Balashun sir, and Raminder ma'am for moderating this session and also supporting this venture. Dr. Nigel, I've known him for some time, so he's indeed a great instructor to be along with during the session. The session, we are planning for the session to be around an hour long and followed by interactive discussions after that with real-time simulation. The session is mainly focused on the updates that is which has occurred in 2020, and we'll be just brushing through what the research has shown and also the normal protocols that we follow. It is somewhat interactive sessions. You can put in your queries and put in your comments in the chat box, and then we'll take it up from there. If everything is okay, then we'll move on to the session. I hope the slides are visible.
Yes, Ajith, you can proceed.
Yeah, fine. So good evening, one and all. So this session is we are mainly focusing on the resuscitation updates, both basic and advanced. Coming into the whole idea about the research and the methodology and how it happened, we'll begin with the whole system, how AHA or how research updates happened. Disclaimer: this is a completely a resuscitation update and not an AHA course. So we both of us are even AHA instructors, but this is just not an AHA course. It's a resuscitation update. The whole research world has been keeping on changing day in and day out, and evidence-based recommendations for resuscitation and also emergency cardiovascular care has shown a pivotal role in our day-to-day clinical practice. Initial guidelines for CPR was published way back in 1966 by an ad hoc CPR committee, but later on, every year since then, every 5 years, new updates started coming in. Till 2015, we saw a drastic change in updates where the whole 1 year or 5 year thing changed into whenever updates are available, they have decided that they will publish it. So that as you all are aware that what is published or what is happening in 2016, when it gets published in 2020 and when we start learning it in 2021, it's already an outdated one, because research is happening in and out every day, every hour. Researchers are coming out. So AHA and all the ad hoc committees have decided that updates as and when it is available, they'll publish it. From there, we come to what is forming these protocols or what is forming these guidelines. International Alliance Committee for Resuscitation, ILCOR, is the cornerstone for all this research and all this updates that is happening. It was formed in 1992, and later on, it started to have a liaison between all the principal resuscitation organization across the world. And through its day-to-day work, they have been creating resuscitation guidelines, and also in a multidisciplinary way, they have been helping each and other country for updating their protocols. The ILCOR committee comprises of the AHA, the European Resuscitation Council, Heart and Stroke Foundations of Canada, Australia and New Zealand Committee on Resuscitation, Resuscitation Council of South Africa, Inter-American Heart Foundation, and Resuscitation Council of Asia. So these are the member organizations, and slowly it gets added on depending on the amount of research that comes out. And ILCOR basically follows extensive evidence evaluation in support with all the ILCOR committees, ILCOR member councils, and all. And evidence are reviewed as a systematic review, or it could be even a scoping review, or it could even be an evidence update. And they put, after doing all these research, they put the whole thing into two terminologies: class of recommendation and level of evidence. Class of recommendation is the strength, and level of evidence is the quality at which. And class of recommendation is basically, it deals with whether it is the whatever has come out, whatever point that has come out, is it reasonable or is it effective enough, or do you have doubt in it? All those are put in class recommendation. It could be class 1, class 2A, 2B. 2B is weak, 3 is no benefit, that means it is not that much recommended, whereas class 3 becomes harm. Whereas level of evidence deals with research. It is basically about randomized control studies, meta-analysis of the randomized control studies. It could be just randomized control studies without meta-analysis, or it could be non-randomized control studies, that is level BNR, means it's non-randomized control studies. And level CLD means it is limited data. And now if nothing goes on, then ultimately it will be level CEO, that's expert opinion. So once you see an article, once you see a point out of it that so and so is the class of recommendation and level of evidence, it becomes very evident or very clear to us that what are we actually looking at. So this is the basic crux of reading through a resuscitation journal. The whole article has been through the published resuscitation journal. We'll be going through the resuscitation journal, and through the from whatever has the data that has come in the updated version, this is how the number of the percentage of class of recommendation and level of evidence is. And around 33% is class 1, whereas 27 is class 2A, 32% is class 2B, whereas 4% is no benefit and 4% is harm. And whereas when it comes to class A, level of evidence A, that is non-randomized control studies, meta-analysis, it is only 1%. Most of them are limited data, that is 51%, and 70% is expert opinion. Now, few of the terminologies, I'm sure that everyone here have been expert in resuscitation, just brushing through the whole thing. And so, a few of the terminologies I would like to bring in is OHCA, that is out of hospital cardiac arrest, IHCA, that is in hospital cardiac arrest, then ROSC, that is ROSC, or return of spontaneous circulation. The whole outcome of adult and pediatric in hospital cardiac arrest is improved tremendously over 2004. Whereas out of hospital cardiac arrest, even though resuscitation is happening, but its outcome has not been showing that steady growth what we see in hospital cardiac arrest. Now we'll bring on the first audience poll. That is, I'll read the question. Pick out the true statement regarding 2020 update on resuscitation. Pick out the true statements regarding 2020 update on resuscitation. A chain of survival remains the same. A new in-hospital cardiac arrest is introduced. A sixth link, recovery, is added to both out of hospital and in-hospital cardiac arrest, chain of survival. And D, the importance of recovery and survivorship for resuscitation outcome is emphasized. Pick out the true statement regarding the 2020 update on resuscitation.
The poll window is projected. You can click on the option A, B, C, D, whichever you feel are right.
It could be statements also, not the points need to be just one statement. It could be more than one.
Yes. Fine, we'll wind up the poll in another 5 more seconds. Yeah, thank you very much. Here's the result.
So I think,
yeah, Dr. Ajith, you can continue.
yeah. So I think everyone has gone for option C. That is, the 6-link recovery has been added on. Excellent. Recovery is a new chain that has been added on to the whole resuscitation cycle. Is there anything else which has been more emphasized or given some more importance than the earlier? Is there anything else? I think there is one more thing that is changed or given more importance is the recovery part, and survivorship was also a bit more given a push in 2020 update. We'll go through that in the slowly in each slides. We'll go through it.
Yes, Ajith, we can move forward.
Okay. One second. Okay. Now moving on to the updates. So as we discussed, this was the earlier chain of survival. Is the poll window up? Are you seeing the poll window? Are you seeing the slides now?
Yeah, slides are fine. Slides are seen.
Okay, fine. So as you can see in the chain of survival, there is a earlier it was mainly what is chain of survival? Chain of survival is basically links which has to be followed. The chain per se is that one is connected with the other, and as the chain is more strong or more connected, the patient is more benefited. So earlier out of hospital cardiac arrest was mainly about recognition and activation of emergency response system. So if you see someone in unresponsive state, you activate the emergency response. This is followed by immediate CPR. This is followed by defibrillation or AED, followed by advanced care where you maybe shift the patient to an hospital, followed by advanced ICU care and all those things. So this was the chain that was before for out of hospital. But in the hospital, the only difference was that it starts with surveillance. So basically, it is always better to identify a pre-arrest condition. If you can identify a pre-arrest condition and manage it, that's the best thing possible. And that is how the surveillance works. It is, if you can, prevention is always better than cure. And it's always better to have a high index of suspicion to prevent a cardiac arrest. This is followed by recognition, CPR, defibrillation, and advanced care. So this is how the chain of survival was going through till 2020. But in 2020, what has happened is a new link. When you look at the whole scenario from a outside perspective, what we can see is you are managing the patient. You are actually giving the patient a post cardiac arrest care, and in the post cardiac arrest care could be an ICU care. But after that, you are not viewing from an angle that the patient should walk out of your hospital. The patient should walk out of the hospital and should resume his previous routine, and that is where our success lies. And that is where the AHA has introduced 6th link or the recovery link to give importance to recovery and survivorship, and that is the cornerstone. I feel that is now the chain is complete. You recognize, you manage it, you give a high care, and then you are now thinking about recovery, survivorship, and even rehabilitation. So that is when the whole chain is complete, and that is where the sixth chain has come into play. And these are the few updates of 2020 highlights. Mainly, it begins with adrenaline, giving more importance to adrenaline. And what is about double sequence defibrillation? We have been hearing that in and out for quite a long time. IV versus IO, then about individualized management of resuscitation, and few more are about post-resuscitative care, improving neuro-prognostication, point-of-care ultrasound for prognostication, recovery and survivorship, real-time motivational feedbacks, and continuous monitoring of arterial and end-tidal carbon dioxide. These are some of the highlights that we have been going through. I'll just go through the previous slide again. So 2020 updates, it started with giving importance to the sixth link, followed by CPR was being reaffirmed. Double sequence defibrillation has been given importance, and it is not about importance, it's about clarity to double sequence defibrillation. IV versus IO, early epinephrine administration has been reaffirmed. Individualized management of certain cases has been given more importance, followed by ultrasound, post-resuscitative care, improving neuro-prognostication, recovery and survivorship, real-time audiovisual feedbacks, and continuous measuring of arterial and end-tidal carbon dioxide. So these are some of the updates or some of the important areas which has been given in adult resuscitation. Now we'll go to a few case scenarios. You can put your answers in the chat. You have a 72-year-old male who has been presented to emergency in an unresponsive state. The patient complains, the bystander complains that the patient has been having chest pain and breathing difficulty for past 30 minutes. So it is a 72-year-old male present to the emergency in an unresponsive state. The patient gives an history, or bystander gives an history that the patient was complaining of chest pain and breathing difficulty for the past 30 minutes. How do you proceed? You can put it in the chat window if you have. How are you going to proceed with this case? It's a 72-year-old man. I'm sure that everyone in this forum will be managing this case pretty well. So I have no doubts about the management. Maybe it's just that we'll have a discussion forum. That's it. It's a 72-year-old ER, unresponsive state, history of chest pain, breathing difficulty. How do you proceed? Okay, we are getting some answers here about defibrillations, vitals, call for help, ECG, call for help, vitals. Excellent. So we'll just see how these all has to follow. Because time is essential. Why we are learning resuscitation is so that things happen from your spinal level, not from your cerebral level, where things should happen like this in resuscitation because there's no time to waste. And there, whenever you see a cardiac arrest, it is always about identifying the cardiac arrest. That's the most important thing. And these are some steps which can help to save a life. It begins with scene safety. All AHA accredited course, all world-renowned courses in resuscitation talks about scene safety because you may be in an environment that is hostile. We as resuscitation, we don't want our team to be compromised. We want to ensure the safety of our team. Even in COVID era, we talk about that. We want safety of our team because once the team is safe, the team is able to manage n number of patients. So that safety is always should be there. So it is about scene safety. This is followed by checking the response. When the patient is responsive, patient is unresponsive. If the patient is responsive, well and good. That's happy news for us. If the patient is unresponsive, definitely that's a code blue scenario, or you may have to shout for help or activate an emergency response. This is followed by checking of the pulse. Which pulse do you check in a cardiac arrest in an adult? Which is the pulse that you want to check in a cardiac arrest? In definitely it's carotid. There's no doubt in carotid because that's the last pulse to go and that's the first pulse to come back. So that's carotid always for that matter. Then once the pulse is palpate, you palpate for maybe maximum of 10 seconds. You're not going to waste time till the pulse comes back. So it's maybe up to 10 seconds you will palpate, and if not, then you are going for CPR, and that is the 30 compressions followed by 2 rescue breaths, and once you get the AED or defibrillator, you're going to attach it. CPR. It's been a terminology that is going in and out. We, as an emergency expert, as anesthesiologist, you all have been experts in this era. So it's continuous CPR that is going to happen. 30:2 cycle, 1:30:2 cycle into 5 cycles becomes 2 minutes, and that's one batch of CPR, or one batch or one cycle. And you know the position, it's in the lower half of the sternum. You're making sure that your hands are properly positioned so that you are also not straining. The power or the strength comes from the back, and that's the fulcrum. This is where the whole power comes. Your hand is just supporting the whole venture, and the position of the hand is also important. The 30 compressions is always followed by the 2 rescue breaths. What does compression means? Compression is basically you're providing an artificial cardiac output. Each compression, you're going to pump out the blood. And once the compression is over and once you relax, that's why we always tell that we need adequate recoil. Once you relax, the heart is going to have a venous return. That is the suction power. And that is artificial venous return that you're going to create. So compression and decompression is important. Not only just compression, but recoil is also important, so that you have adequate blood to pump out for the next compression. And the depth should be minimum 5 to 6 centimeters, or it should be 2 inch to 2.4 inch. If you can see here, we have mentioned about the class of recommendation, the level of evidence, and that's the cornerstone about all that. Then the rate should be 100 to 120 compressions per minute, and you also recommend about layer rescue CPR whenever you see a patient in cardiac arrest. Better to start it as and when you can see the patient, or as and when you are aware that the patient is in cardiac arrest. Now coming to the next poll, true statement, pick true statements regarding chest compression in CPR. Option A is chest compression rate is 100 to 120 per minute. Depth is 5 to 6 centimeters. Allowing adequate chest recoil. Compression ventilation is 30:2. Change compressors every 2 minutes or sooner if fatigued. The poll window will be open. Dr. Saneesh will handle that, and you can pick your choice.
Yeah, whichever you think are correct, you can click. Yes, we would like to hear from more audience. So you can post your remarks now. Make your voice heard. Another 5 seconds, the poll will be closed. Yeah. I think things are reasonably clear.
Amazing.
Yeah.
So we'll just re-emphasize those points. So 5 key aspects of great CPR, or that you are amazing and doing a great job. Is rate of compression is 100 to 120. The depth is 5 to 6 centimeters. You are providing an adequate recoil so that you have adequate venous return for the next pumping. Ventilation is 30:2. Here I want to insist, ventilation doesn't mean that you have to put an intubated or you have to put an ET tube. It just needs to be a proper ambient. You need a chest rise. That's more than enough. We don't want to break CPR for intubating. Clear that in your mind. What you need is chest rise. What you need is ventilation. If we can achieve that with a proper ambuing, that's well and good. Then the last and most important is be uninterrupted. Don't break it. Don't take an like if you want to attach the defibrillator, you're going to break the whole scenario. If you want to put a cannula, breaking the whole scenario. Don't do all that. The whole sequence should go like an engine which is running without any break. So re-emphasizing, rate of compression is 100 to 120. Depth should be 5 to 6 centimeters. Adequate recoil. Ventilation should be 30:2, and it should be uninterrupted. Great. Now, going to the next update, the early incision of CPR by layer rescuers. Lots of discussions, lots of confusions, lots of concerns have been whether the patient is in actual cardiac arrest. We don't know whether the patient, it's basically about layer rescuers. whether the person is lying unresponsive on the roadside, should we do an CPR, whether we are producing more damage to the patient. So even the Resuscitation Council has been thinking about the whole thing, and they have brought in the 2020 update, which fixes and which clears the whole our concern that it is always better to initiate CPR for a cardiac arrest. And why? Because studies have shown that new evidence have shown that the risk of harm to a victim who receives chest compression when not in cardiac arrest is very low. Lay rescuers are not able to determine whether the accuracy, whether the patient is having pulse or not, but risk of withholding CPR from a pulseless victim exceeds the harm from an unattended chest compression, and that clears all our doubts. Risk of harm, if the patient, unfortunately, imagine the patient is having a pulse, the patient was unresponsive, the patient is having a pulse, you accidentally did a CPR. Nothing to worry because the risk is low. Maybe the patient will catch hold of your hand and say, "What are you doing?" But still, that's something, some way to check the response of the person. So the risk of harm is low, and the risk of holding back CPR from a pulseless victim exceeds the harm from unattended chest compression. So go ahead. If you see a patient is unresponsive, go ahead with CPR. Now, once the CPR part is over, ventilation part is over. Now, how do you proceed? What is the next step? You're done your CPR, you're done your ventilation. Now the patient is still in cardiac arrest. What is the next thing that you have to do? You can put up the options in the chat window. Once he sees few options, you can take it up from there. Okay, drugs. You can think about drugs. Yes. Anything else? The patient is in cardiac arrest. CPR is ongoing. Ventilation is going. Excellent. People have started to say defibrillation. Check ECG. Beautiful. You connect a defibrillator. Once you connect a defibrillator, your options are only two: shockable, not shockable. Keep it simple. Which are the shockable rhythms? Okay, VT, VF, excellent. Do you want to expand VT a bit more? Okay, it is VT, VF, yes, definitely. Yes, PVT, that is pulseless ventricular tachycardia, because ventricular tachycardia can have pulse also. Then that comes under the definition of tachyarrhythmia with pulse and tachyarrhythmia which is wide complex. So it comes under the definition of that. So we are talking about pulseless ventricular tachycardia and ventricular fibrillation. And what are the two non-shockable rhythms? PA systole, excellent. So the whole shockable rhythms comes under VF and pulseless VT, whereas non-shockable rhythms comes under the definition of pulseless electrical activity and asystole. Excellent. Now identify the ECG. I'm sure that is just a piece of cake for everyone. Excellent. It's VT. It's Y complex regular tachyarrhythmia. Y complex regular. Once you see in a monitor, you're thinking about ventricular tachycardia. Because as you know, we have a PQRST complex. QRS complex represents ventricular depolarization. So QRS complex, whenever it is widened, you are thinking about ventricular pathology. And whenever QRS complex is widened and regular, you are thinking about ventricular tachycardia. Whenever things are regular, you put a name tag mostly as tachycardia. So here we are talking about ventricular tachycardia because it is Y complex and it is regular. Excellent. Then, so that is clear. Now identify this. Beautiful. It's Y complex, and is it regular or irregular? Excellent. It's Y complex irregular. As we told earlier, Y complex QRS, you're talking about ventricular. Y complex irregular, you're putting a terminology fibrillation. So it is ventricular fibrillation. So Y complex irregular is ventricular fibrillation. So that is also clear. These two are shockable. Now what is this? Okay, everyone is sticking on asystole. Does anyone want to change your opinion? Whoever has done resuscitation courses would be knowing what more to think about when you see this. Excellent. Someone has put it flat line. Excellent. This is flat line. You can't terminal or you can put it as systole until and unless you do the straight line protocol. Straight line protocol is basically checking whether the leads are connected, whether changing the leads 1, 2, 3, and increasing the amplitude. Even if after doing all this it is still straight line, then you call it a systole. And the last one, what is the CCG? Or what do you do when you see the CCG? I'll put it like that. When you see you are doing a cardiac arrest, after 2 minutes you assess and you see this rhythm. What do you do next? I'll just wait a second. I'll clear the question. You are doing CPR. You connect to the defibrillator 2 minutes after your whole rhythm analysis. After 2 minutes, you assess the rhythm. You stop it. What do you do next? Excellent. You check the pulse. And when you check the pulse, you have only two options: either pulse or the pulse is absent. If the pulse is present, ROC is achieved. Excellent. You have done a great job. If the pulse is not present, you are now talking about pulseless electrical activity. So 4 rhythms to remember: VFVT, shockable, systole, and pulseless electrical activity. The 4 things. So whenever you see an organized rhythm, this comes under definition of organized rhythm. You check the pulse. If pulse is present, this pulseless ROC is achieved. If pulse is absent, then you are thinking about pulseless electrical activity of PEA. So now coming to the whole algorithm. So you have a patient, you started your CPR, you connected the defibrillator. We'll come to this part. You saw the shockable rhythm, VF and VT, pulseless ventricular tachycardia and VF. You did the shock. Then CPR is continued. Then after 2 minutes, you again assess. You did the shock. Then you gave the first dose of epinephrine. Then again after 2 minutes, you assess. You are doing again giving the shock if it is again shockable rhythm. And then you are thinking about amiodarone. So I'll just put it into nutshell and just brief it off. So whenever it is a shockable rhythm, you give a shock, you continue CPR. And you ask your team to secure the IV line and load the first drug. And the first and foremost drug is adrenaline. So you have 3 things to do. You gave a shock, then you have 3 things to do. You continue a CPR, you put a cannula, ask someone to load and keep adrenaline. 3 things. CPR, IV line, load and keep adrenaline, and you can also ask for the history of what has happened. So 3 things. Now, after 2 minutes, you again assess the rhythm and you see it is again shockable. And you shock. Now again, you have 3 things to do. Deliver the first dose of epinephrine, load the next drug, that is amiodarone 300 milligram, and think about the 5H and the 5T, that is a reversible causes. Hypoxia, hypovolemia, hydrogen ion excess, hyper or hypokalemia, and hypothermia. 5H. Hypovolemia, hypoxia, hyper or hyperkalemia, hyperacidotic state or hydrogen ionic state, and hypothermia. That is 5H. And 5Ts, that is toxins, tension pneumothorax, cardiac tamponade, pulmonary thromboembolism, cardiac thromboembolisms, and that is again the 5Ts. So you think about the 5H and the 5Ts. So 3 things that you do: you give the adrenaline, you load the amiodarone 300 milligram. Then the third thing is you think about 5H and 5Ts. If you can clear that, you clear that. Then after 3 minutes, you assess. You do the next 3 things. You give amiodarone 300 milligram. You load the next dose of adrenaline, that is 1 milligram, and you then think more about the 5H and 5Ts, whether you have missed up something, whether you want to send more lab samples. Think about that. That cycle keeps on moving on. So briefing it off, you see a shockable rhythm, shock, CPR. So that is the first thing that you do. The second cycle, if it is again shockable, you do shock, CPR, adrenaline. Then again shockable rhythm, the shock, CPR, amiodarone. Then again after 2 minutes, it will be shock, CPR, adrenaline. Then again shockable, it will be shock, CPR, amiodarone 150 milligram. And that's all. 2 doses of amiodarone, and that's it. Adrenaline keeps on happening every alternate shock if the shockable rhythm continues. Hope we are clear on that. Now coming to non-shockable rhythm, that is PE and assistor, it's very easy to manage it because there is nothing shockable coming in the play. Here, the change that has happened is this. As and when you can give epinephrine, even before CPR you can give. So epinephrine ASAP, as well as some terminology which has come in. As soon as possible you give epinephrine. Then it is CPR. So it will be CPR and epinephrine. You continue that. Every 2 minutes you assess, it will be CPR and epinephrine. But one thing, think about the reversible causes, the 5H and PTs. Hope this is clear. And after 2 minutes, you see an organized rhythm, you check pulse. If pulse is present, done. Your job is done. You have achieved ROC. But your job is not complete because you need to do a post cardiac arrest care also. So that is the whole nutshell about this algorithm. Hope that is clear. If you want to discuss or if there is any confusion, we can take it up in the Q&A session. So early administration of epinephrine has been re-emphasized, reaffirmed that epinephrine should be given as soon as feasible for non-shockable rhythm, whereas for shockable rhythm, epinephrine should be given after the initial defibrillation attempt has failed. So that's what, after first dose of shocking, then you think about giving epinephrine. The whole why it has changed, because epinephrine has shown to increase ROAC and survival. So that is a benefit that we have with epinephrine. Now coming to double sequence defibrillation. Double sequence defibrillation is basically when you see a shockable rhythm, you can place one pad on your upper part of the right chest, the other part on the other pad on the apex. Then another pad is kept below the first pad and below the apex pad. So basically you are connecting two defibrillators. And you give one shock, that is 200 joules. Then maybe after that shock is given, you give one more dose of 200 joules. And certain people have thought that, okay, this is beneficial. But studies have shown that it cannot be established. So by studies, what has come into play is double sequence defibrillation is the practice of applying near simultaneous shocks using two defibrillators. But ILCOR systematic review has found no evidence to support this. So there is no evidence to support double sequence defibrillation, and it is recommended against its routine use. If that is clear. So there is no double sequence defibrillation in the whole cycle. Now coming to IV or IO axis. I'm sure that most of you are experts in IV. IO at certain situations we may have to put it mostly in pediatrics. So what has happened is earlier it was like if you don't achieve an IV, you go for IO. But now it is more maybe probably because of the research is happening and all those. What is now recommended is that IV route is always associated with better clinical outcome, and all the IV axis is preferred. For situation in which IV axis is difficult, IO axis can be a reasonable option, but always try IV multiple times. If you still don't know, if still not getting IV, you can go for IO, but IV is more emphasized because IV are shown to have a better clinical outcome, and that's why IV is given more importance than IO. Earlier, it was both as given equal importance. If you don't get IV, you go for IO. Now, IV is given much more importance, and IO only if nothing is happening, okay, you can go for IO. That's how the whole review has happened with IV and IO. Now comes to real-time audiovisual feedback. There are lots of CPR feedback devices, like you keep while doing a CPR, you keep a feedback device on your chest, and you can place your hand over that and use CPR. So it alerts your compression rate, it alerts your compression depth. So all these small, tiny changes in your CPR mechanism has shown to have better outcome when it comes to patient care. So recent RCTs have reported that 25% increase. 25% is a huge number when it comes to survival in out of hospital discharge, in hospital discharge from in-hospital cardiac arrest with audiovisual feedback. So audiovisual feedback definitely has a definite role for improving the survival in cardiac arrest. Now coming to physiological monitoring of CPR. Physiological monitoring of CPR. I'm sure that lots of people have been using physiological monitoring mechanisms while doing CPR, while giving CPR, and that are mainly the ETCO2 or arterial line placement. Whether it is beneficial. Now, we as resuscitation, while doing as a team leader or while we are giving CPR, we don't know what is actually happening inside. Okay, we follow the protocol of 100 to 120. We follow the protocol that it should be 5 to 6 centimeter, but we don't know actually what is happening. So now the physiological monitoring, like if you're not in line, you're tracing the artery line, see what is happening. If you have an ETCO2, you are seeing, okay, ETCO2 waveform. And by each compression, the perfusion is going to happen. And each perfusion is going to bring back blood to the lung. And each bringing back blood will deliver carbon dioxide, which is going to diffuse into the alveoli. And that is going to be exhaled through the through the ETCO2. And if you can monitor that, and if you can maintain that at 10 to 20 mm Hg, then you are actually doing a good CPR. Now you are a parameter to view and to say that I am doing well. Now that is being more emphasized. So 2020 update with lots of resuscitation mechanisms. What I have shown is that targeting compression to an ETCO2 value of at least 10 and ideally 20 or greater may be useful as the CPR quality measurement. Now we are in an era of quality improvement, quality studies. Quality of the CPR can be improved. It's not just what you do. You need an output, and that is measurable. That's well and good, and that is ideal to maintain at 20 mm Hg. An ideal target is not different, but still more than 10, around 20 is good enough to say that you're doing a good CPR. If that is less, you should improve your CPR quality. Now, giving that nutshell with all this, now CPR, now resuscitation has come to a point that you think about individualized management. And individualized management, not only that maybe it is just opioid or it's cardiac arrest in pregnancy, but lots of cases which we, from a point that you think about beyond the routine CPR, they're going to manage the patient from that patient point of view rather than a general point of view. And that will help in improving the outcome of the patient. So now we will be talking about individualized management of CPR resuscitation. Dr. Nigel will cover across the opioid overdose and cardiac arrest in pregnancy.
Thank you, Ajith. Now you can take a short break. So anyways, I think you'll have to play my slides as well.
Okay.
I think when it comes to the new guidelines, if many of you had seen some of our previous lectures when it came to resuscitation, we had taken even the ECC guidelines. We had even gone through the European Resuscitation Council guidelines, and there we had talked about different scenarios like drowning, frostbite, and things like that. So I think in this scenario where we see some changes, that is where opioid overdose has been specifically mentioned. Cardiac arrest in pregnancy also has been specifically mentioned. And we will just run through those slides as well, just to give you an overview. So opioid overdose, as we know, causes respiratory depression. It can lead to respiratory arrest and cardiac arrest. And a suspected opioid overdose who has a definite pulse, but no normal breathing or only gasping. So that's what we call about a respiratory arrest. So it's important, to administer intramuscular or intranasal naloxone, and this is with evidence. So we all know about naloxone being an effective opioid antagonist. It can be administered either IV or IM or even intranasal or even subcute. But we give it IV because it has the most rapid onset. So the initial dose, as we know, for naloxone is about 0.4 mg to 2 mg intravenous. So this empirical administration of intramuscular or intranasal naloxone to all unresponsive opioid-associated life-threatening emergency patients may be reasonable as an adjunct to standard first aid. So in many new protocols, we'd see the inclusion of naloxone also in basic life support. Next slide. So this is the slide which shows how they have incorporated opioid-associated emergency for lay responders in an algorithm. Okay. The algorithm is pretty much the same. We check whether the patient is breathing normally or not after all the ABCs, as we just reviewed a little earlier. So it's either we start CPR, and immediately we give naloxone as well if you are suspecting a opioid overdose. Now, like I was telling you, the initial dose of opioid that we give is 0.4 mg to 2 mg IV. This can be repeated, as I told you, at every 2 to 3 minute intervals. And when we repeat it at 2 to 3 intervals, we wait and watch up to 10 minutes. See, this is the question that many people would ask: how many doses can we give? That's the question that people ask with epinephrine. That's the question which you will see with atropine. That's the question which now people are asking about naloxone as well. So the answer for that would pretty much be that, we wait and watch for 10 minutes. And if there is no response in terms of the opioid antagonism, then the diagnosis that we have of an opioid toxicity can be questioned. That is the basic idea. So like we had already gone through with regard to, the BLS sequence, again, so when we suspect an opioid poisoning, we check for ABCs, responsiveness, call for help. So the only thing is they included getting naloxone also into this. And otherwise, it's basically the same, pretty much the same algorithm that we have. So you can consider giving naloxone if you're expecting a patient to actually being as an overdose of opioid poisoning. Now, this is something which has been specifically included in the algorithms, that is the cardiac arrest in pregnancy. And we felt it was important to touch upon this as well, because this is something that is very important and many times it is not stressed upon. Cardiac arrest in pregnancy, we know that pregnant patients are more prone to hypoxia, oxygenation problems, airway management issues, and all of these should be prioritized during resuscitation from cardiac arrest in pregnancy. So we know that in most of these patients, pregnant patients, they have weight gains, breast engorgements, the swollen mucosa, the difficulty to intubate these patients, how the decrease in their functional residual capacity and their oxygen reserve reducing, how all that affects their greater risk or causes, puts them at a greater risk for hypoxemia. So because of these potential interferences with maternal resuscitation, all these things, that is the weight gain, the difficult airway, we should also consider that fetal monitoring, might be difficult during cardiac arrest in pregnancy. So another important point that the new guidelines have stressed upon is to recommend targeted temperature monitoring for pregnant women who remain comatose after resuscitation from cardiac arrest. And during targeted temperature monitoring of the pregnant patient, it is recommended that the fetus be continuously monitored for bradycardia as a potential complication, and obstetric and neonatal consultation should be sought. So whenever we have a scenario like this, there should be a multi-team involvement in the resuscitation plan, so as to protect the life of the mother as well as the life of the child eventually. Next slide. So now this is with regard to the evidence. So like I already mentioned, airway, ventilation, and oxygenation are particularly important in the setting of pregnancy. Like I told you, because of an increase in maternal metabolism, a decrease in the FRC due to the gravid uterus, and the risk of fetal bed injury, which results from the resulting hypoxemia. So this is basically the idea or the evidence that we're talking about, or the reasoning. So this is the new algorithm that we have, with regard to the cardiac arrest in pregnancy in hospital ACLS algorithm. So what we need to understand is that, like I was telling you, there should be proper team planning between the obstetric, neonatal, and the emergency team comprising of your anesthetist or your ICU physicians. So basically, whatever cardiac arrest services that you have in the hospital, there should be a multi-team disciplinary approach to this. And the priorities for the pregnant women in cardiac arrest should include provision for a high quality CPR and the relief of aortocaval compression with lateral uterine displacement. So that is something that many a times we forget, to inculcate when it comes to pregnant women. Many scenarios, if you have a pregnant patient who suddenly has a peri-arrest or a scenario like a cardiac arrest scenario, we should always remember that the relief of aortocaval compression is also very important to improve the morbidity. The goal of perimortem cesarean delivery is to improve maternal and fetal outcomes, and ideally we perform the perimortem cesarean delivery in 5 minutes. So depending upon the provider resources and skill set. So that's part of the guidelines now. So basically we go for experienced hands when it comes to securing the airway and when it comes to delivering the baby as well. So in pregnancy, as I told you already a few points earlier, we anticipate a very difficult airway. So the most experienced provider has been called in, should be called in, and we provide endotracheal intubation. That is priority. If you're not able to intubate this patient with the endotracheal tube, then maybe you can include a LMA. But LMA always stands a chance. Laryngeal mask airway always increases the risk. There is always a risk of regurgitation and aspiration. So definitely the priority would be to secure the airway with an endotracheal tube. And then we perform waveform capnography to confirm and monitor ET tube placement. That is as per normal ACLS guidelines. And once the advanced airway is in place, we give one breath every 6 seconds. So the potential etiology that these guidelines stress upon is A, B, C, D, E, F, G, H. There is anesthetic complications. That also I spoke to you about. The anesthetic complications would be multiple. We talk about one is the airway management, the response to anesthetics. There are we give a number of anesthetics to the patient. So all these response, there could be a decrease in the minimum alveolar concentration, decreased functional residual capacity. We know that there is increased minute ventilation and rapid overdose with loss of airway reflexes when it comes to the response to anesthetics. Then we should be careful when it comes to excessive hyperventilation as well. So all these things, and our target should be to avoid maternal and fetal hypoxemia. So all these things we need to inculcate along with taking care of bleeding. That is basically that can lead to hypotension. Cardiovascular involvement. We know that in most of these patients, venodilation may be an issue. And when we're talking about bleeding as well, we should remember that a healthy parturient, that is a pregnant healthy parturient, will also tolerate maybe up to about 1.5 liters of blood loss. So we need to keep that in mind as well. But excessive bleeding and the cardiac involvement might actually predispose our patient to a hypotensive state, which might also compromise the oxygenation of the baby. Number of drugs that we use, that also needs to be considered. Any embolic phenomenon, that also needs to be considered. Fever has also been mentioned. And H's and T's, that is as per ACLS guidelines, and also any maternal hypertension, any predisposing conditions like eclampsia or preeclampsia. So now coming down to the algorithm quickly. So we consider once we have a peri-arrest scenario or a pregnant lady who is going into a cardiac arrest or who is already in cardiac arrest, we consider high quality CPR, defibrillation, and other ACLS interventions like epinephrine. So early epinephrine is again indicated. We call for help, that is from the multidisciplinary team. And we consider the etiology of the arrest. So A, B, C, D, E, F, G, H, with whatever is the causes that we need to enumerate and see. So we perform maternal interventions, that is perform airway management, that is intubate the patient if possible, 100% oxygen, but avoid hyperventilation. Ideally place the IV above the diaphragm, and if receiving IV magnesium, stop and give calcium chloride or gluconate to prevent hypermagnesemia. Obstetric interventions that we already mentioned about should be to provide continuous lateral uterine displacement. That is very important. I'm again stressing on that because that is very important to relieve the aortocaval compression. detach the fetal monitors, because this can actually hamper your resuscitation efforts, and prepare for perimortem cesarean delivery with experienced hands. So if no ROSC in 5 minutes, it's immediate perimortem cesarean delivery, and we involve the neonatal team to receive the neonate. So these are the basic, significant points that have been added when it comes to cardiac arrest in pregnancy. So you will take over, Ajith.
Now, this was till now was about arrest management. Now we came to a point that we are thinking about post-resuscitation care. As we are told earlier, it's not about arrest, getting the pulse back, your job is completely done. Where the post-resuscitative care comes into handy. What is this post-resuscitative care? Post-resuscitative care means soon after arrest, soon after reviving a patient, the patient may not be hemodynamically stable. It is our responsibility to make sure that the patient is hemodynamically stabilized, and also it is our responsibility to identify the pathology and correct the pathology, and is also that this patient doesn't arrest again. So it is not a simple job that we have in our hand. It's a complex of event. And identifying pathology itself is a big, huge burden, because most of the time the patient which comes to us, we may not be knowing even what the history the patient had. So that post-resuscitative care is the most challenging area. It's not about getting the pulse back. I'll put it very black and white. It's not getting the pulse back that is important. It is stabilizing the patient, identifying the pathology, correcting the pathology. That is where we play a major role. So if I would say, it is about identifying the pre-arrest, managing the pre-arrest, preventing an arrest. One major hurdle that we have, managing the post arrest, that the post resuscitation care is the another hurdle that we have. The arrest, if you have the team, if you have the protocol in place, it should go very well. These two chains needs to be very strongly bounded together to make sure our patient succeeds and goes back home pretty well. Here comes the next Q&A. The Q&A question starts with, which are the following are considered in the neuro-prognostication in post-resuscitation care? Neuro-prognosticative things in post-resuscitation care. Clinical, A is clinical examination, B is serum biomarkers, C is electrophysiological test, and D is neuroimaging. Out of this four, or multiple options can also be there, which are the entity that goes with neuro-prognostication?
I'm winding up the poll in 5 seconds more. Yeah, whichever you think are involved in neuroprognostication, you can click on it.
Okay, most percentages with clinical examination. Then second is with neuroimaging. Third is with electrophysiological test, and last is serum biomarkers. Okay, well and good. Now we'll go in detail about it. What is neuroprognostication? What do you think about neuroprognostication? Neuroprognostication is basically an environment or an entity that we do to understand that how much the brain has damaged. We don't know what has happened before the patient has reached here. We only rely on the history. We don't know the time when it has happened. We don't know where it has happened. We don't know how it has happened. And we don't know the comorbidities most of the time. So it is our responsibility to make sure, okay, you have done the resuscitation. What has happened? The patient may be tubed, patient may be in the ICU, and we need to know that clearly how much the patient can survive. And that is about neuroprognostication. And neuroprognostication is multi-edged, multi-sword, multi-facet. because we need to know multiple things to know and clearly say about it. And there comes the role of that getting incorporated as a critical component in the whole resuscitation mechanism. So critical component of the chain of survival, where the multidisciplinary thing has been given more importance, where, as we told, post-resuscitation will come into neuro-prognostication a bit after the post-resuscitative care. So here, post-resuscitative care is a bridge to make sure that neuro-prognostication is also working pretty well. So what is post-resuscitative care? As we had discussed earlier, stabilizing the patient hemodynamically is all about post-resuscitation care, where you need to stabilize the airway. Maybe the patient may not be tubed, you're ampooing till now. The patient, you're after after ROC is achieved, you check the pulse is present, okay, ROC is achieved. Now you're going to check the response, whether the patient is responding. Okay, you check the response and you see the patient is not responding. That means that the patient is not able to maintain his airway. Once the patient is not able to maintain his airway, it is our responsibility to intubate the patient and secure the airway. And that is a step one. So airway stabilization. Second thing is about breathing. You have to make sure once the airway, once you're tubed, always followed by tubing is about looking that the tube is in place. ETCO2 is there. Waveform capnography is the gold standard. Then you have ultrasound guide. You can use ultrasound. You can use the 5-point auscultation method. So make sure that the tube is in position. Make sure that the oxygenation is also right. Make sure the saturation is maintained. And make sure the saturation is well properly 90 to 96% is maintained. So that is about C. B. And C is about circulation, where you're checking the pulse, you're checking the BP, stabilizing both, and also taking a 12-lead ECG to identify whether there is any cardiac pathology. Now moving into the D part, that is A, B, C, and the D part, where in the D part, you are actually thinking about identifying the disability, how much is there. And the disability part is basically you are thinking whether the patient is responding properly. Again, after stabilizing A, after stabilizing B, after stabilizing C, you are re-evaluating the D part and you are again checking for response. If the patient is responding properly after stabilizing ABC, job well done. But if the patient is not responding properly after stabilizing ABC, then you are thinking about making sure that the patient's brain metabolic rate is reduced, and that is achieved by targeted temperature management, or TTM, which was previously called as therapeutic hypothermia. So TTM, or targeted temperature management. So that is where you C part comes in, or D part comes in. You stabilize the airway, you make sure the tube is in position, you make sure that in the B part, you make sure the saturation is achieved. In the C part, you make sure that the pulse and BP is stabilized. You took a 12-lead ECG to make sure that, okay, there is no pathologies in ECG wise. Then in the D part, you make sure that the patient is neurologically active or not. And then you cleared out and you identified whether the patient is, if not responding, if the pupils are not responding, you're thinking about targeted temperature management. And also in simultaneously, you can think about sending the bloods for sampling. So post arrest, once you achieve the pulse, you are going to stabilize airway, breathing, circulation, and disability. And then the intervention starts from there. So basically, post-resuscitative care is the whole nutshell. So once the patient is achieved, once the RSU is achieved, you manage the airway. So that is A. You place the tube. This is the initial stabilization. You place the tube, you secure the tube. Then you make sure the tube is in position. Gold standard is, which is the gold standard, I've already talked about it. The gold standard about tube positioning or endotracheal tube position is, it's almost 1 hour post session, so it's better to have some interactions in between. So which is the gold standard to confirm endotracheal tube position? So it is quantitative waveform capnography, where you are actually getting the value, where you are going to target it. The PaCO2 should be maintained between 35 to 45. The saturation should be maintained at 92 to 98%. So A and B is stabilized. Now you come to C, where you are checking the pulse, you're managing the pulse, you're checking the systolic BP, maintaining it more than 90 mmHg, mean arterial BP maintaining more than 65 mmHg. You are taking a 12 lead. don't forget to take 12-lead ECG. Don't depend on the defibrillator after ROC is achieved. We need a 12-lead ECG because 12-lead ECG gives us a much better clues than the defibrillator. You can clearly say whether the patient is having an STEMI, whether the patient is having a AVR ST elevation or inferior wall ST elevation or an anterior wall ST elevation or an inferior wall ST elevation or even a posterior wall ST elevation. You can also clearly check and say whether the patient had a new onset LVB. You can clearly say the patient is having a heart block. You can even think about the patient is having a bigeminy. You can even think about the patient is having a any sort of arrhythmias in that pathology which has contributed to the primary pathology of the cardiac arrest. So lots of clues are going to get, and don't forget to look at the QTC, the QT, corrected QT interval. And normally you have a QT is corrected with the heart rate, that is QTC. Don't forget to look at that because that gives us a lot of clue about electrolyte disabilities or electrolyte disturbances. So you get a better clue with that 12-lead ECG. And also you get a clue whether the patient had an hyperkalemia because you are going to look at a Dalton-T waves, whether you are going to look at whether there is a even hypokalemia, that is whether there are any prolongation of the QT interval, whether there is a sine wave pattern. There are lots of clues that you're going to get with the 12-lead ECG. And make sure also do an ultrasound, an echo, an adjuvant, see the ejection fraction, see whether there is a RA-RV dilatation, see whether there is a D sign, see whether there is a RV collapse during diastole, and these gives a clue. Just a question here. In an echo, you see an RA-RV dilatation. Post-arrest, what is the take on from that? RA-RV dilatation on the point of care echo, post-arrest, you see RA-RV dilatation. You're going to think about something. Excellent. PE, you're thinking about pulmonary embolism. You have a diastolic collapse during RV diastolic collapse. You're thinking about cardiac tamponade. So you have interventions to do there. Don't forget about that. Then you're thinking about whether you want to manage a cardiogenic shock at that point, whether what support you need to start. You're thinking about that. So A, B, and C. You manage the C. Now you're going to check the D part where you're again responding, checking for response, following the commands. Now the patient is telling, okay, responding. He's opening his eye. He's holding a hand up, patient's hand up. So he's responding to what you say. Okay, the ABC is stabilized. The D part is functioning properly. Yes, the patient is fine. We can go for next intervention. But if the patient is not responding after stabilizing A, B, and C, the patient is still comatose. Think about targeted temperature management. It is a bit hurdle in our environment because it's not about the initiation of targeted temperature management. It is about continuing the targeted temperature management. That is a hurdle. And how do you monitor the target? How do you do the targeted temperature management? It's a lot of entity together. You have an IV line. You can start on IV fluids. You have a Ryle's tube. You can start on cold saline. You have a Foley's catheter. You can start on cold fluids through the Foley's catheter. And you can have a you know about the cold blankets where you're going to cover the patient with the head, the ear, the head part. You're putting a complete blanket like a warmer. You're doing the complete opposite of it. You're cooling the patient. And where you're going to target 32 to 36 degrees Celsius, and you're going to maintain it for 24 hours. And that maintaining for 24 hours, what you're indirectly coming up to is you're reducing the metabolic rate. You're going to reduce the basic metabolic rate. And once you reduce the basic metabolic rate, whatever has damaged, that damage progression can be avoided, and that healing is given time, and that will help in a better outcome. So targeted temperature management is the patient is not following commands. You're going to start TTM and you're going to maintain at 32 to 36 degrees Celsius over for 24 hours using the cooling devices whichever is available. And you have to monitor the temperature. That's another hurdle that we have. You should have an esophageal temperature monitoring device. It could be a pulmonary artery catheter temperature monitoring device. So you should have an internal temperature monitoring device to make sure that the temperature is maintained. Otherwise, you're going to play with something else. You're going to make the whole scenario change into hypercooling, followed by you're going to have a coagulopathy, which is followed by acidosis. The whole sequence of another triad starts up. So it is not about targeting or cooling the patient. It's about maintaining that cooling under monitoring. It's very important. And once the TTM is started, you go for the next critical management where the patient go for an extensive care, where ICU and all the expert care comes in play. So this is a nutshell about stabilizing a patient. So you did the whole ROIC. Now you are going to stabilize the airway. Now you want to stabilize the breathing, saturation at 92 98 degree, maintaining PaCO2 between 35 to 45, getting the systolic BP up to 90, diastolic mean above 65, getting a 12 lead, clearing out all your confusions and clarity, getting a clarity about what is happening, get a point of care echo, get a point of care lung scan, have check for B lines, check for do the blue protocol, whatever you can, you have learned about ultrasound, do all the focus possible, point of care ultrasound. You can do everything. You can do even check the IVC, see how the IVC is, check the B lines, check the lung sliding sign, whether you're going to see whether there is a pneumothorax or not. So all this can be incorporated to make sure that you stabilize the ABC. Now D part, think about if not responding, think about targeted temperature management. So this is stabilizing the patient. Once this is done, you get a proper vitals. Okay, well and good. You have stabilized the patient. You can go even send all the bloods, send an ABG. Don't forget about ABG. Do that also because you may be dealing with high metabolic acidosis. You may be dealing with a high osmolar gap metabolic acidosis. You may have forgotten that whether it's a methanol poisoning or an ethanol poisoning, or you may have a oximeter to rule out whether it's a methemoglobinemia or a thymethemoglobinemia. So all this can give us a better clue about the post-cardiac arrest management. So this is a nutshell about post-cardiac arrestment. So post-cardiac arrestment follows with neuro-prognostication, follows with a point where you get a clarity what has happened to the brain. And that is not a single entity, it's a cumulative of lots of entities. And where multimodal neuroprognostication helps in the dealing the patient. But make sure that you do the neuroprognostication after 24 hours because you have been doing targeted temperature management and the patient is hypothermic. Hypothermic, you're resting your brain. So make sure that it is normothermia before you do neuroprognostication. And neuroprognostication is all this. You start with clinical management. So you have done the 24 hours target temperature management. You've done the rewarming, that's another 24 hours. Then you have limited your sedation analysis, see how the patient is responding. Imaging part, initially it's CT, then it's MRI to see whether there is any hypoxic injuries. Electrophysiologically, you have the N20 SSEP. What is SSEP? That's somatosensory evoke potential, the sensory potential evoking the brain, see how the brain activity is happening. Then you have followed by the clinical examination where you have a do and recorded EEG because you don't know the patient is having an absent seizure happening in the brain or it's a non-convulsive status epilepticus that is going on. So get a recorded EEG. Then also the neuromarkers, that is the neurospecific analysis, that basically neuroblastoma, but it can be used in NSA, can be used in markers as neuroprognostication. High value of it is something that you have to be careful about. So all this multimodal approach gives a better clue that what you are actually dealing with, whether the patient is recoverable, whether how much you can stress, how much you can go beyond this to make sure the patient is survivable. So this is a multimodal approach. So it is a continuation of post-cardiac arrest care. After 24 hours, when the normothermia is there, you go for neuroprognostication so that you get the clarity about how to go forward with it. As we have discussed, the point of care has already been discussed. It's not, it's a multimodal. From the point of starting the cardiac arrest till the last, even you can do an papillary edema monitoring with a optic nerve sheath diameter measurement with an ultrasound. So all the small entity can be used with ultrasound, and that gives a better clue about how the patient is happening, and it gives a clarity about what is happening inside. And it has always, the ultrasound has become a part of resuscitation, and it is also helps in identifying whether the patient is having any reversible causes of cardiac arrest. Now the last part is the recovery and survivorship. So it's not about treatment, it's about surveillance, it's rehabilitation, getting the patient back to what it was. Structured assessment about anxiety, depression. The patient can have a post-traumatic stress disorders, manage that. Fatigue, concerns about the patient. Make sure that it is all these are addressed. You may have to have a multi-team approach for that. And this is about physical, neurological, cardiopulmonary, and cognitive impairment can happen for the patient. Make sure you correct all that. Medical and rehabilitation treatment recommendation before return to activity has been a class 1 recommendation. So make sure that you get it completely clear. Your patient is well back to be walked to a state where he was before. So putting all together, 2020 updates have clearly brought in certain new things out of the normal resuscitative cycles. It is not just about stressing on CPR. It is not about the it is not about the double sequence. It is taken off the double sequence defibrillation. It is stressing on IV more than IU. Epinephrine, much more role, given a higher priority for epinephrine. Individualized management of resuscitation like opioid, pregnancy, these have been given more importance. And it has also given ultrasound an upper hand where it can be used from the point the patient comes in till the patient goes out of the hospital. You can use ultrasound as an adjuvant. You're going for post-resuscitative care where a ABCD approach, a complete stabilization, thinking about targeted temperature management is also achieved. You're thinking about improving neuro-prognostication with all the multimodular MTTs like clinical examination, neurospecific inlays, the SSEPs, the MRIs, all this has been the EEG, everything together. You're working on the patient recovery and returning back the patient to a normal status. Real-time motivational feedback, which is increasing 25% of the survival, and also physiological monitoring like ETCU, which gives us a clue what is happening during resuscitation. So all this is a sum up about how resuscitation is, how resuscitation updates are happened. This is a reference that we have, the Circulation Journal 2020, the ECG guidelines on and also highlights of 2020 American Heart Association guidelines. So these are the reference that we have. And with that, it's a whole nutshell about resuscitation. If there is any queries, any confusions, either in the chat or in the mail, anywhere we can take it up. And we are happy to clear all this. And it's a greeting from College Medical College, from Dr. Nigel, our team, and also from the Emergency Medicine Association India. Thank you for bearing with us. Thank you for being an active participant throughout. Now I think we'll, if there is almost it's 8:30, we can go for the simulation part. Or maybe after that we will take questions.
Thank you, Dr. Ajith and Dr. Nigel. Yes, Dr. Saneesh can take over now.
Okay, I think we have some enthusiastic delegates waiting to take up the scenarios. First, I'll tell the rules how we are planning the mega code scenario run-up. We'll select volunteers to run the code like a team leader. I think now we have 4 team leaders, so we'll have 2 persons for each scenario. So 1 person will start the scenario. At some point, we'll switch to the next team leader, and the scenario will be introduced. Then you will have the live hemodynamic monitor appearing on your screen, so you can respond accordingly, be it cardioversion or defibrillation, whatever the team leader decides, it will be performed accordingly. Whether right or wrong, we'll decide later. So during a mega code, things will go as the team leader decides. So I request the delegates who are volunteering to introduce yourself first. I think, can we have Dr. Arun Mohan and Dr. Perbin for the first scenario?
Yes, sir. Myself, Dr. Arun K. Mohan.
Okay.
I'm a post-diploma DNP resident in anesthesiology in Luz Hospital, Kochi.
Okay, fine. Dr. Perbin? Dr. Perbin, are you with us? Okay, fine. So I think Dr. Arun can take the scenario now.
Yes, sir.
Okay. So you have a 72-year-old gentleman who is a non-hypertensive diabetic patient coming with chest pain to the emergency room. Okay. And he is in distress. He is having diaphoresis.
Okay, sir.
He is in the ER. You can start managing the case. So you can clarify with me for any details, and we'll proceed like.
Yes, sir. I'll just examine the patient, sir.
Okay.
Make sure what is vital, sir. Check for the response of the patient.
Okay. Patient is right now in distress. He can answer your queries, but he is in distress.
I will connect the monitors, attach monitor the BP, assess the scene safety. Then
No, he is in the emergency room. Like
yes.
there is no question of.
Yeah, he is having from the monitors. I can see that he is having a heart rate of 164 beats per minute and saturation of 89.
Okay.
So it looks like a narrow complex regular tachycardia.
Okay.
He is in supraventricular tachycardia, I hope, and feel for the pulse.
Okay, pulse is present, feeble.
So I will go ahead with the adult tachycardia algorithm.
Okay.
So he is having a heart rate of around 160. So I will start with a synchronized cardio version.
Would you like to have his blood pressure?
Yeah, his BP, sir.
Okay.
What is his BP, sir? Arterial BP is showing flat line, sir.
No.
So,
arterial BP is not connected. We will get a non-invasive blood pressure.
Okay. Okay.
That will appear on your screen now. Okay, it's 9844.
9844. So systolic BP is about 90. So he's in a stable condition, sir.
Okay.
So I will connect the monitors, provide O2, and give a supportive management and regularly check for the pulse.
Okay, fine. So he's having diaphoresis. Now his blood pressure is falling to 80/44.
So I'll again 80/44. So I would like to see if the perfusion is maintained, mean arterial pressure, and the pulse. If it is palpable, I'll again give the assess the reversible causes of causes and then correct it.
Okay. So meanwhile, he's still having chest pain, ongoing chest pain.
So I will, and the ECG is changing to a VF, sir.
Yes.
Ventricular fibrillation.
Yes.
So I will assess the pulse again and immediately start the CPR, sir.
No
and
pulse,
activate the emergency response team.
Okay.
And check and continue and start the CPR, high quality CPR, sir.
Okay. So you have started high quality CPR. You have activated the emergency response system or code blue inside the emergency room. Okay.
Code blue, sir. Yeah.
So you have the team with you. There is somebody volunteering for chest compression. One person, sir. Anesthesiologist, has come for airway management, and we have one person in your defibrillator connecting ECGs.
Yes, sir. Yes. Now the roles has been assigned. A secure IV line, an IV line has been secured already.
Yes, IV line is there. Yes.
Yes, sir. Now we'll start the CPR at a rate of 30:2 in compression,
Okay.
and 30:2, sir. Compression rate at a rate of 100 to 120
yes,
per minute.
That is taken care of. Yeah.
Then for 2 minutes.
Yes.
And the rhythm is shockable, sir. So I'll go ahead with the defibrillation.
Okay. What energy you want to defibrillate?
200 joules.
So I'm charging. So what instruction you'll give to the team?
I should ask for scene all clear. Everyone should be clear, and then apply the shock and continue CPR, sir.
Okay, I'm giving the shock. Yeah. Okay.
To continue the CPR and check the quality of the CPR.
Okay.
Then and the person who is loading the drug has to take care of the next shot of adrenaline.
Okay.
Has to be loaded.
Mm-hmm.
And continue the CPR.
Okay.
And
so again, 5 cycles of 30:2 chest compressions given.
Yes, sir. And if possible,
at the end of 2 minutes, you are seeing this on the monitor.
This looks like a VT, sir.
Yes.
Ventricular tachycardia, and I
Yeah.
have to check the pulse again.
Yeah, no pulse.
No pulse, so I have to continue the CPR
Okay.
and do the defibrillation once ready,
Okay.
and
Okay.
1 shot of adrenaline, sir, 1 mg IV.
Okay.
Then load amiodarone for the next cycle if it is a shockable rhythm, sir.
Okay. Fine. So,
And
so what you will be telling to the person handling defibrillator? I am in charge of defibrillator.
Defibrillator, I will ask for giving a defibrillation at a energy of 200 joules.
Okay. Shall I charge for
Yes,
200?
sir.
Yes.
Yes.
I'm charging. Yes. Ready.
All clear?
All clear? Yeah. I'm giving the shock.
Yes. Now the heart rate is around 120, looks like a sinus tachycardia, sir.
Okay.
And pulse is palpable.
Okay.
Now the ROC
You
has
are
been,
definitely feeling a pulse. Okay.
yeah, yes, sir. Then ROC has been achieved,
Okay.
and the patient has to be taken for the post-resuscitation care, ROC.
Okay.
Support definitely calls for the has to be ruled out. The arrest has to be ruled out. Most probably a patient presented with a chest pain, most probably a myocardial infarction.
Okay.
So 12-lead ECG has to be taken. Oxygen should be provided to maintain a saturation of 92 to 98%,
Okay.
and mean arterial pressure of systolic of more than 90 millimeter mercury.
Okay.
Then end-tidal volume waveform capnography has to be seen, sir.
Okay. So you have secured the airway with the endotracheal tube.
Yeah, airway, he has to be intubated with to secure the airway tube. Then patient's GCS with the patient response has to be assessed.
Okay. There is no response to Weber commands.
So we have to proceed with an ICU management with targeted temperature monitoring,
Management.
EEG monitoring. If any seizure, seizure activity is seen, and other critical care management. Sir.
Okay. Would you like to have a 12-lead ECG?
Yes, sir, sure. Because the patient presented with chest pain, I would like to have a 12-lead ECG.
Okay. Okay. Fine. Okay. We'll stop simulation at this point, and we'll go to Dr. Nigel for the debriefing.
Dr. Arun, how did you perform? How do you think you performed?
I think I performed, but a few of the points I think it has to be in order, sir. Otherwise, it was okay, sir. I think.
Your patient is still alive?
Patient has achieved the ROC. We have to see the neuro-prognostication and all.
Okay. Overall, yeah, it was good. I think as we progress, maybe with the next scenario, I think again it'll improve. So there are a few things that I'd like to touch upon now, since we are dealing with the mega code and the debriefing session. See, when you're going to be tested, part of any standard course, there are certain guidelines to be tested as well. So we are looking as instructors, we'll be looking at certain points as well. So the first and foremost point with many of you might not actually inculcate would be your role as a team leader. That is also very important, and that is always assessed by the instructors. What we mean by your role as a team leader, it will include both. It will include your involvement of team dynamics as well as your role as an effective team leader. So as a team leader, there are three things that we check: whether you are ensuring high quality CPR at all times, whether you are assigning your team member roles, and whether you are ensuring that your team members perform well. Okay. Now, what we mean by ensuring or making sure that your team members perform well is basically the most important points that are highlighted in team dynamics in CPR. Now, I'm going to touch upon in short about the team dynamics also. We know that during resuscitation times, these are tense times, which might lead to maybe a lot of emotions getting out of control. And it's very important to be calm and composed as a team leader to have total control of the situation. So during a code, we'll have many members standing there in the hospital as well, if it's in the hospital. And if you shout at someone, if you yell at someone, you can have different kind of emotions taking over. So, as a team leader, make sure that before you start any resuscitation, always assign clear roles to each team member. So you would have a team, and assigning clear roles to the team member is very important. So that is also, we actually, as an instructor, we actually check whether you are actually assigning your team member proper roles. Okay, and as a team member, if you are given a role that you are not competent enough at, you can always let the team leader know that, I would like another role. So do not take a new role by yourself. It should always be under the supervision of the team leader. For example, now you might have a shoulder dislocation problem, you might have a spine problem. So you are not able to perform chest compressions effectively. So you have to tell your team leader about this. And this is also known as knowing your limitations. So this is also part of team dynamics, knowing your limitations. Then assigning team member roles, that is important. These are, there'll be one person who will be taking care of compressions. There'll be one person taking care of the ventilation, one person with the defibrillator and the monitor that is on the same screen. So you'd have the monitor on the defibrillator as well. Team leader, as you were just now, you would have a person recording the whole scenario with the timings, and one person for the IV medications. Okay, so these are the things. Now, the team leader should be in complete control of such a scenario, and no team member should feel that he's being bossed upon, because this is not an ego scenario where we play. This is going to be teamwork. So as a team member, you must follow a closed loop communication to prevent errors in giving orders. For example, if you say, give 1 mg epinephrine IV with a rapid saline flush, the person who's giving the IV should communicate back saying that, yes, 1 mg epinephrine IV given with a rapid saline flush. So the loop that is opened by the team leader is closed by the team member. That's what we mean by a closed loop communication. The loop is opened by the team leader saying that give this medication with the route and the dose, and the loop is closed by the team member by saying that I have administered so and so, and if you think that he's giving a wrong dose, as a team member, if the wrong dose has been given by the team leader, he can politely tell the team leader that sorry, I think this is what is the right dose. This is what we mean by sharing knowledge and constructive criticism. So these are things that you should be careful about as a team leader and as a team member. Okay, and things to avoid, remember always, one is do not push a colleague, and you don't have to openly criticize your colleague in a negative manner such that you tell him that he's not doing his role well. Nothing like that. Push hard, push fast. We need effective good chest compressions, good rate. This is what our aim is. Okay, do not yell as a team leader at another team member. So the same point, I'm just reinstating that. And do not get offended as a team leader when you are being corrected also. That is also important, because most importantly, it is the outcome of the chest compression or the outcome of the resuscitation that is most important to us. And do not respond with an incomplete loop of communication, like I already stressed earlier. So complete the closed loop. So this is what I meant by, we check the role of a team leader. Meanwhile, doctor, you also correctly diagnosed the initial rhythm as an SVT. That is good. Now, in the tachycardia management, it is very important to start oxygen, place the monitor, starting IV access. Okay. Now, these three things we always reinstate and we always tell. That is monitors, IV access, and oxygen on every patient that is coming to you. So that is what is important. You recognized the tachycardia. Now, the important thing to understand is whether it is a stable or an unstable tachycardia, or this is the same when it comes to a bradycardia as well. You have to know whether it is a stable or an unstable rhythm. Okay, it can be the same for tachy and brady. So what are the things that you would check to know whether your patient is stable or unstable? Can you just tell me?
Yeah, I should see the sensorium of the patient, sir. Whether
Okay,
he's following command.
Altered mental status.
Mental status, yes.
That
Whether
is basically you communicate with the patient, you try to talk to the patient and see whether he's oriented to time, place, and person. Next.
Whether the patient is in shock, whether BP is hypertension is there.
Okay, so hypotension and signs of shock. Very
Yes.
good.
Then whether any chest, the patient was having chest pain, so probably like chest discomfort, breathing difficulty.
Excellent. So any ischemic chest discomfort. Very good. Then
the
one more point.
Heart failure, I think, sir. Yeah.
Excellent. So an acute heart failure. So basically, the first thing is you look at the monitor, you check for the BP, hypotension, talk to the patient, you see whether he's responding to you, whether his mental status is proper, signs of shock, look for his extremities, whether it is cold and clammy. You look for any ischemic chest discomfort. Maybe in the ECG, you might find any ST segment changes. Any acute heart failure, you need to auscultate and look for any crackles. So all these things need to be checked. And even if one of this is positive, that is any one of this is there, that means this is an unstable rhythm, unstable tachycardia in this case. So what is your management for an unstable tachycardia?
A synchronized cardioversion, sir.
Okay. So in the case of a synchronized, what are the steps of a synchronized cardioversion?
First, the patient has to be sedated.
Before sedation, always remember most of these patients would be awake and talking to you. So you have to talk to the patient and take consent from the patient, first of all, for cardioversion.
Yes, sir.
Okay, so always convince the patient that you are going to give a shock to the patient. Before you shock, you will sedate the patient. And then after taking his consent, then you consider sedation. Okay. So when you talk about cardioversion, what are the doses of the cardioversion that you know?
Lower doses like 50 joules to 100 joules.
For what? For what rhythms?
For supraventricular tachycardia.
Okay. So you had a supraventricular tachycardia, right?
Yes, sir.
So your patient was stable or unstable?
Patient was having a hypertension later on.
Okay. No, initially
he was stable, sir.
Okay. So your patient had a stable SVT.
SVT.
Right?
Yes, sir.
Okay. How do you manage a stable SVT?
Stable SVT can be managed with drugs, sir, like adenosine 6 mg in the IV dose.
Okay, very good.
Followed by a rapid flush. And if it is not reverting, it can be repeated with 12 mg repeat dose, sir.
Okay. Before that, you can even try the vagal maneuvers.
Vagal maneuvers, yes, sir.
Okay. So now in the case of a situation wherein you have an unstable tachycardia, unstable SVT, you have to take consent from the patient, sedate the patient, and then you are going to cardiovert the patient. And what is the cardioversion? The shock that the recommended dose of shock that you're going to give?
50 to 100 joules.
Yeah, you start with 50 and then you go up to
100. Yeah.
So suppose your patient had an atrial fibrillation. What would be the starting dose? It would start at 120 and go up.
120 and go up. Yes.
Okay. Then if it is a ventricular tachycardia,
VT, it is a shock, sir.
Yeah. How much?
200 joules. 200 joules.
100 joules. It starts at 100.
Okay.
So that's how we go about the management of tachycardia. And generally, when you manage a tachycardia scenario, the next thing that these patients would generally go into a VF or a pulseless VT. Okay. So in your patient, you had a VT with no pulse. So it's important to even check the pulse at that time, the carotid pulse, to make sure that there is no pulse. And early defibrillation, early epinephrine.
Yes,
okay. And then we continue with our VF and pulseless VT, the cardiac arrest algorithm. Okay. So I think most of the things you went well. The drugs also were mentioned. And then your patient went, and then finally you went into ROSC, right?
Yes, sir.
Did you have a PEA or asystole before that?
No.
Okay. So
We have-
generally,
we have-
what did you say?
No, sir. There was no assistol in this.
Okay. So generally what happens is you might have a PEA or asystole also before that, which needs to be diagnosed and treated. And it is at that time, one very important thing needs to be done. That is, you need to discuss the H's and T's.
Okay. 5 S's and 5 T's.
Yes, that is the time when we discuss about the H's and T's, and then we discuss about, and then your patient went into ROSC, and that's the time when we discuss certain things about ROSC. As Dr. Ajith had earlier mentioned, inside ROSC, very important is to take a 12-lead ECG. Very important thing it is. So inside the ROSC, establish all the vitals of the patient. Very important. Okay. Then you need to treat each and every aspect of the vitals. So suppose your patient has a low BP, you need to treat that. If your saturation is low, you need to treat that with intubation. So you have to ensure your BP and 12-lead ECG are performed. Oxygen saturation is monitored. You should verbalize the need for endotracheal intubation, waveform capnography, and also you should order your laboratory tests, including your ABGs if needed. Okay.
Okay, sir.
And sometimes during the H's and T's itself, you can send for the investigation so that by the time you reach ROSC, you have the investigations in hand.
Correction, yes, sir.
And also the last thing would be targeted temperature management, as we already discussed earlier.
Okay.
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 Anything
Okay,
that you would like to add? Anything Dr. Ajith would like to add?
No, I think I mean, even though it is a first simulation, he has done pretty well. He has covered everything possible. ROC has achieved. Post cardiac arrest management, he has started on that. So in a nutshell, has been managed properly. Only thing, as Dr. Nigel has explained to you, the importance of team dynamics, importance of how you make sure your team goes along with you, and how well they are responding to what you are saying is also important. And this scenario of COVID, when you are in PP, when you are in a mask, when you are in a face shield, nothing of your expression is going to be seen by the other person. The only thing is verbalizing properly, and verbalizing is is the most important thing, and that's what is the giving the most important decisions during resuscitation. One more thing I want to ask is, if it is a stable SVT, a stable narrow complex tachyarrhythmia, what is the first step that you have to do?
Connect oxygen, sir.
Okay, you have connected the oxygen. You understood it is you stabilized A and B. Now in the C, you are looking into stable tachyarrhythmia, narrow complex.
So vagal maneuver can be given.
Okay, how do you give vagal maneuver?
Ask the patient. Turn the neck to the right side, left side, and give a small massage over the carotid triangle.
Okay, fine. You are giving a carotid massage, basically. Do you want to do something before you do a carotid massage?
Make sure that atropine is loaded. Maybe he can also go for arrest, possible.
Okay, that's fine. Before you give a carotid massage, you have loaded atropine, fine. You have a 12-lead ECG to say it is narrow complex tachyarrhythmia. You're not dealing with anything else. Anything more that you have to do?
Yeah, we have to rule out the bruise. Any carotid bruise. Possibility.
Okay, so carotid bruise has to be ruled out. How do you rule out a carotid bruise?
Auscultation of the carotid, sir.
Okay, so you have to auscultate the carotid, make sure that there is no bruise, and make sure that it is clear to intervene.
Yeah.
What is revert trial?
Sorry, sir.
Revert trial. REVERT. Revert trial.
No idea, sir.
So it's basically a modified Walser method to convert SVT. It's basically something that we normally have done, it blowing into a needle, basically blowing into a syringe, where it is again creating a negative pressure, creating an effect of vagal stimulation.
Okay.
So
Well,
that studies has commented that it is also effective enough. So even the carotid bruit cases, you can even go for this.
okay. Okay.
Otherwise, I think everything was covered in detail. Nothing else. I think you have covered everything in clarity.
Okay, Ajith.
Thank
We
you.
have one more.
Well
day.
done. It's properly done.
Do we have time for one more scenario?
Yeah.
Okay. Dr. Denny?
We can go for a quick one.
Yeah. Dr. Denny?
Yes, sir.
Can you introduce yourself?
My name is Dr. Denny Abraham Chari, second year postgraduate resident in Sehgal Medical College.
Okay, fine. So your case scenario goes like this. Okay, a 61-year-old lady who is a non-diabetic, hypertensive, and post coronary artery bypass graft patient is she's reporting to emergency room with history of palpitation and uneasiness, lightheadedness. So here is the ECG in front of you. Okay, arterial BP is not there. Yeah. Dr. Denny, you can.
Yes,
see the
sir. So
monitor?
this
Yeah.
patient, according to the rhythm, sir, I feel she's in a block, sir.
Okay.
Atrioventricular block. There is a skip beat.
Okay. Fine.
So I would examine this patient, maintain the
Okay.
patient's airway,
Mm-hmm.
give oxygen, sir.
Okay. So she's having slight diaphoresis. Blood sugar is shown to be 250.
So in short, sir, I'll try to
blood pressure
distinguish.
is also falling. Now the blood pressure is coming down to 88 by 44. Yeah.
In short, sir, the patient is hemodynamically unstable.
Yeah.
She's hypotensive.
Okay.
So she is having any, how's the level of consciousness, sir? Any acute?
Yeah, she's able to respond to your questions. Though she's tired, she's having lightheadedness.
Yes, sir. So any cold, clammy extremities, sir, signs of any
Yes.
shock.
Yes.
Yes, so in short, the patient is unstable. So I would prefer to give atropine,
Okay.
0.6 mg first dose. So I would like to repeat it like every 3 to 5 minutes.
Okay.
Maximum,
So
I would give around 3 mg.
okay, fine. So now the patient is persistently diaphoretic, and ECG rhythm slightly changes now.
Yes, sir. So, but still the block is still not reverted.
Yeah.
So I'll consider epidural, epinephrine infusion. Okay, so
now
the
she's
patient,
unresponsive.
yes,
Now she's unresponsive.
So now the patient has gone into assistole. So the patient.
Are you sure it's assistole?
A flat line.
Okay.
So pulse, no pulse.
Yeah, you are not sure about the pulse. Yes.
Okay, so I'll make sure if the monitors are connected, is there any disconnection from the monitor side?
Yeah.
That straight line protocol.
Yes.
So I'll immediately start CPR, sir, for 2 minutes.
Okay.
I'll maintain an IV access.
Okay.
Sir, I'll start with epinephrine, sir. I will ask my colleague to give epinephrine.
This is after 2 minutes of CPR?
CPR for 2 minutes.
Okay. I mean to say CPR for 2 minutes and then injection epinephrine?
No, sir. During CPR.
During CPR.
During CPR,
how much?
Sir, 1 mg IV. So I'll consider to intubate the patient also, sir. Any intratracheal intubation.
Okay.
Consider an advanced airway. So then after 2 minutes, I'll reassess the rhythm. So the rhythm is still flat line, assistole. So I'll continue with my CPR for 2 minutes. So I'll think about the five H's and 5 T's, sir. The reversible causes. So I'll try to rule out that. So after 2 minutes of CPR, sir, I'll again reassess the rhythm.
Okay. So this is the rhythm you are seeing on the monitor.
So sinus rhythm is come, sir, but then there is ST elevation. Sir, I would like to maintain the patient's ventilation.
Would you like to stop CPR at this point?
Yes, sir. Yes, sir. Stop CPR.
Okay.
Pulse is
But
there.
your colleague says he or she is not definite about the pulse, central pulse.
Pulse is not there. So then it can be a pulseless electrical activity, sir.
Yes.
So then I would continue my CPR.
Okay.
Okay, so for 2
Fine.
minutes. Yes,
Okay. Any drugs?
sir, epinephrine every 3 to 5 minutes I will be repeating, sir.
Okay. Fine. Any role of defibrillation? Because I am ready with the defibrillator.
No, sir. This is a pulseless electrical activity, sir. It's a non-shockable rhythm, sir. So I don't,
Okay.
don't want to use it.
Okay. Fine. And after another 5 cycles of CPR,
Yes,
so
sir.
your colleague says during assessment says she can faintly feel the pulse.
So, if pulse is present and so if there is a rhythm, so then I will go into the ROS post-cardiac arrest algorithm.
Okay.
Sir, and then I'll optimize the ventilation oxygenation, sir.
Okay.
In short, sir, I maintain the saturation levels of the patient, oxygen saturations.
Okay.
Sir,
So your colleague is in put the endotracheal tube, and
yes,
it's confirmed by waveform capnography.
so the blood pressure of this patient is.
Blood pressure right now is 86/44.
So I would like to give an IV bolus, sir, a normal saline 1 to 2 liters bolus.
Okay.
For being a lactate.
Okay.
So then I'll also consider vasopressor infusion, sir.
Okay, fine. So now blood pressure is slightly picking up, 110/53.
Okay, sir. So I would like to take a 12 lead ECG, sir, just to rule out because this patient is.
Okay, fine.
Yes, sir. So
then what else you would like to check?
So if the patient is following commands,
Okay.
if he's responding to my questions,
Unable to respond to verbal commands.
if not able to respond, so then I would like to go for a initiated targeted temperature management, sir. I would like
fine.
to, with the help of cooling blankets, 36 degrees Celsius.
Okay. So ECG shows ST elevation. So you will
then
route the
obviously,
patient
sir,
to the ICU through the cath lab.
Cath
Okay.
lab, sir, and
We'll
then-
wind up
yes,
for
sir.
short of time. Excuse
Okay,
me
sir,
for
sure.
that.
Yeah,
Dr.
sure, sir.
Ajith, your comments.
Yeah, Dr. Denny,
Yes, sir. Yes, sir.
excellent, well taken. How was the scenario?
Good, sir. Thank you, sir.
How did you feel about managing it? Were you confident? Were you comfortable with it?
Yes, sir. It's fine.
How was your team supporting you in this?
Yes, sir. They were responding to whatever I said, sir. So it's good.
Okay, they were responding back to you. Was there a closed loop communication? I think Dr.
Yes, sir.
Saneesh
Yes,
is
sir.
giving a good closed loop communication. Okay. So what was the initial? How was the rhythm? How did the patient present to you? It was a 61-year-old with diabetes, palpitation. The patient had uneasiness presenting to you. How did you feel about the initial rhythm?
So that I was a bit confused, sir, but then I thought there was a skip beat.
Can you be a bit more loud?
So I thought I was a bit confused in the initial rhythm, sir.
Okay.
But then I thought there was a skip beat and there was a PR interval. I thought there was still waiting PR interval. So I thought it was an AD block, sir, but I don't. Not that sure,
Okay.
sir.
Then later on, you were able to identify the rhythm, right?
Yes, sir. Yes, sir.
Yeah. What is the rhythm that came to you?
So second degree AD block, sir.
Okay. So basically, there's a bradycardia, and you identified that as a heart block, second degree probably. Yeah. So was the patient stable or unstable at the point?
Patient was
take
unstable, sir, because of the signs of shock and.
Okay. So how did you identify the instability? How did you feel that the patient was unstable?
Patient was hypotensive, sir.
Patient was hypotensive. Excellent. Anything else to say? What are other things that we normally identify?
Level, so the patient's level of consciousness was.
Okay, consciousness. Yeah. I think the patient was the patient conscious oriented?
Yes, sir. Yes, sir. Initially, yes.
Okay. Okay. Fine. Then the BP was dropped. How was the peripheries also you would examine, right? Why do you have to examine the periphery?
So signs of shock, sir. Cold clammy
Excellent.
extremities.
So you're also looking at
decreased
signs of
perfusion, sir.
shock. Okay. Do you want to auscultate the chest,
Yes, sir.
roll out something?
Yes, sir. To rule out heart failure, sir, I would hospitalize the chest, sir, to see if any fractures.
So it is altered mental status, ischemic chest pain, cardiac failure,
Yes, sir.
signs
So
of
the
shock,
patient is,
hypertension. All this comes under the big
yes, sir.
broad hurdle of instability. So the patient was unstable. What if the patient was stable? What if
Yes, sir.
the patient's BP was fine? The patient was bradycardic, but BP was fine. How do you manage it?
So the patient is hemodynamically stable and bradycarditis, I would just monitor, sir.
No,
Monitor.
I was asking if the BP was stable.
And so what about the other signs, sir? There are 5.
Okay, all others are normal. There is no signs of instability. If the patient
Monitor
is
the
stable,
patient, sir.
so it will be stable bradycardia. Do you
Yes,
want to
sir. I'll drop
intervene
in.
for a stable bradycardia?
Initially, I'll monitor, sir, but in case if the heart rate goes very low, sir, I will give atropine, sir.
Excellent. So if the patient is, you're looking at a patient who is stable bradycardia, you're going to observe the patient. This case, you had an unstable bradycardia and you intervene. You intervene correctly with atropine. Then you currently supported with all the other supportive measures. Then later on, patient, I think the rhythm changed into something. What was the rhythm changed into?
So it was a systole, a flat line.
It changed into a straight line. You identified that as an assistol. You were able to get your team together to identify it was assistol. Then you managed with CPR and epinephrine, right?
Here an epinephrine, sir.
Okay. What is the dose of epinephrine that you gave?
So 1 mg, sir. 1 mg.
1 mg. What is the dilution of epinephrine that you have to give?
So 1.
Is it 1 in 1,000 or 1 in 10,000?
1 in 1,000.
1 in 1,000. Always it is 1 in 1,000. 1 milligram, 1 ml, 1 in 1,000 dilution.
Yes,
So that's what you gave. You continued the CPR. The patient was you're resuscitating well. You even thought about 5H and 5Ts. You are evaluating that too. Then later on, something came up, an organized rhythm came up, I suppose.
yes, sir.
And you
There
checked the
was
pulse.
there was no pulse, sir. So the pulse is
But there was no
articular.
pulse at that point. Okay. So if it was a pulse, you would call it as?
So if there was a pulse, sir, then patient gone to ROSC, sir.
Okay, excellent. So if the pulse was present, it's wrong. Because the pulse was not there, you took it as a PEA.
PEA.
And you again managed with CPR and adrenaline. Excellent.
Yes.
And then later on, you were able to get the pulse back. You did the flow chart of post-cardiac arrest. It was very well covered. You took a 12 lead. You were suspicious of an MI in between. Then you went into a targeted temperature management also. Do you want to push the patient to a cath lab? Is it needed?
So there was a ST elevation also, so in between, sir.
Okay, so because you did not clearly get an ST elevation, you did not think about MI at that point. Fine, well and good. If you had a ST elevation, I'm sure that you would push for a cath lab.
Yes, sir. Yes.
Definitely.
Sorry for interruption. I think, Dr. Ajith,
And that's
I think that epinephrine as early as possible should have been reinforced.
Yeah,
updates.
excellent. I mean, good thing that
Once we get the non-shockable rhythm.
Whenever you got a non-shockable, that's one thing that you have to pick on. Say that okay, epinephrine will be given now itself. You have because this patient came before. Maybe you had a line before. So even before you start you ask them to start a CPR. You can ask the IV staff to give the epinephrine 1 milligram, and that could have gone simultaneously or even one step before. Otherwise, I think everything was covered. I think the whole scenario of Brady with an arrest, then followed with a PEA, then followed with a ROSC, then followed with a post-cardiac arrest, and now we are also thinking about the neuro-prognostication and all those things. And that's very well covered. Good.
I think I'll clarify, like in our simulation, actually, we were in a fast forward motion, like 2 minutes over. Actually, in real life, 2 minutes, 120 seconds is good enough time to do a lot of things, to get your next step ready, as Dr. Ajith has mentioned, and to get your team listen to the feedback devices, because AH is now recommending real-time feedback devices. So institute those feedback devices, improve the quality, and maybe plan ahead. Maybe if you need any more clues from a short targeted history, you can send somebody for that. You can review the case sheet in between, because team leader is usually now more free to think about the differential diagnosis. I think AHA has already also mentioning about a role of CPR coach, because ultimately all the BLS skills do matter. So CPR coach will take care of the effectiveness of the compression, the rate, the depth, avoiding excessive ventilation and things like that. The team leader can sit back and think on how to troubleshoot this scenario. So team leader is more free to think in those lines from the 2020 guidelines, I believe. So I feel really sorry for going fast on these simulations, because we are already running short of time. Raminder ma'am, your mic is not enabled. Like you need to unmute, ma'am. Raminder ma'am.
Sorry. Yeah. So it was an excellent presentation, and I compliment both the students who, PG students and residents, who did an excellent job. They could diagnose and they, by and large, managed quite well. And of course, the two people who debriefed, Dr. Ajith and Dr. Singh. So I think that was a very good presentation. So Dr. Denny, would you like to say something?
Madam, it was very good, madam. It really helps us a lot. Good exposure.
Because this is an important part of an examination now, right? Even for MD and as well as DNB. So when you go, so I think this has become a prominent part of things. So, and of course for patient care as well. Thank you everyone. And Dr. Saneesh, of course, as usual, he has done a good job.
Radhakrisnan sir, your comments?
Yes, I am hearing. It was an excellent show. Thank you all very much. I really congratulate Ajith and Nigel for discussing it very well, and that too in an elaborate style. Anyway, now I really feel we should have another session at the earliest on pediatric cardiac life support in the AHA recommendation guidelines, which probably we may be able to do it in a month's time. And once again, I thank everybody for participating. I request Dr. Jayashree to make the formal vote of thanks.
Jayashree ma'am, you can unmute. Yes.
Thank you very much. Of course, it was an extensive topic, but everybody was so engrossed that nobody really realized what the clock said, and we were all just logged in, and we was all concentrating on the topics. And thank you so much for that simulator session as well. And as Dr. Radhakrisnan said, that surely we'll have a pediatric ACLS or pediatric life support webinar as well. So thanks a lot, the moderators, the speakers, and the students, all of you. Thanks a lot, and good night.
Thank you.
Thank you, Rami. Thanks a lot, Rami. Good night. Thank you so much.
Thanks, Nigel. Thanks, Ajith.
Thanks a lot. Thank you, Saneesh.
Thank you.